Good day, everyone, and welcome to another screencast in Immunology and Serology. I am your professor for the day, Dr. Supachoy Basit, and we are already in the final term, and this is already chapter screencast. We will be discussing immunodeficiency diseases. Okay, so for the chapter overview, we will be enumerating the differences between the primary versus the secondary immunodeficiency diseases. And then, of course, what are the different classification of primary immunodeficiencies, the different immunologic defects in selected the laboratory testing for immunodeficiency. So let's discuss first what do you mean by immunodeficiencies. So generally speaking, when we speak of immunodeficiencies, these are considered as disorders in which part of the immune system is either missing or dysfunctional. Having said that, if you are immunodeficient, it means that you will have a decreased ability to defend your body against infections. It could be bacterial, viral, or fungal, or you'll be more susceptible to develop carcinoma or cancer. So that is the reason why being immunodeficient is very challenging task. I mean, it will really take a toll in our immune system. Okay, so primary immunodeficiencies could be inherited. Okay, so it is inherited, and some of them are actually X-linked. So if it's X-linked, it means that males would be more predisposed to be immunodeficient as compared to female. Okay, and then it could also be autosomal recessive or autosomal dominant. Now, when we speak of secondary immunodeficiencies, um, it could be caused by an infection such as an acquired immunodeficiency syndrome, which is caused by the HIV virus. Okay, it could also be due to autoimmunodeficiency, malignancy, or for those patients who have just undergone tissue transplant, they are actually um, drinking immunosuppressive drugs, and that would also make them immunodeficient. So these are examples of secondary immunodeficiencies. So for this particular chapter, we will devote ourselves in discussing primary immunodeficiencies. Okay, so immune system components affected by primary immunodeficiencies could be subcategorized into three. Okay, so we have the humoral immunity, the cell-mediated immunity, and innate immunity. So obviously, when we say humoral immunity, it is primarily caused by defects in B cells or even by T helper cells. Okay, so as we all know, B cells will eventually become plasma cells, and plasma cells are important for the production of antibodies. Therefore, if you are deficient with B cells, you wouldn't expect your body to produce a normal amount of antibodies. So in this particular case, patients would be susceptible to bacterial infections, okay, especially sinusitis or otitis media. On the other side of the story, we also have the so-called cell-mediated immunity. So when we say cell-mediated immunity, this involves T cell deficiencies. So T cells would be responsible for cell-mediated immunity. And of course, when we say cell-mediated immunity, they are responsible for those pathogens that are already intracellular, so such as a virally infected cell. So without T cell function, it will be difficult for our immune system to destroy target cells. So intracellular pathogens, by the way, do not only refer to viruses, but it may also refer to fungi and some bacteria. So example of bacteria that can actually cause intracellular infection would be chlamydia, for example. Okay, and it would also make us susceptible to cancer. So as you can see, either humoral or cell-mediated immunodeficiency could also make a person susceptible to cancer. So innate immunity can also be affected by the primary immunodeficiencies. So when we say innate immunity, this also refers to natural immunity or non-specific immunity. So here, neutrophils or macrophages would be affected, and as we all know, these neutrophil or macrophages are important for phagocytosis. Okay, so without them doing their job, we will be more predisposed to have bacterial infection. And then, of course, complement, which is another important component of natural immunity. So, component deficiency would also lead to various bacterial infections and even, to some extent, autoimmunity. Okay, so as you can see in this illustration, these are PID examples, primary immunodeficiency examples, and their effect on WBC. So the illustration here would only tell us that there are different examples of immunodeficiencies, and they may actually affect the production of antibodies, as you can see here, or the function of the T lymphocyte, as you can see here. So um, different functions, or different categories of immunodeficiency would lead to alteration into the normal function of the WBC. Okay, so for example, as you can see here, um, a person has the X-linked SCID or the severe combined immunodeficiency. So we will be discussing that later on in specific, but I just want to illustrate in this particular example that a person with SCID would have an effect in the function of the IB. So when you say IB, this refers to immature B cells, and also the IT here, this refers to immature T cells. Okay, so if I were you, I would be studying this particular illustration so that you'll be able to know what particular function of WBCs will be affected for a certain example or for a certain type of immunodeficiency disorders, particularly that of primary immunodeficiency for that matter. Okay, so there are actually 9 categories of the primary immunodeficiency disorders. So this could be the so-called combined immunodeficiencies. So could be combined immunodeficiency with associated or syndromic features, predominantly antibody deficiencies, diseases of immune dysregulation, congenital defects of phagocytes, number, function, or in some cases both, defects in innate immunity, autoinflammatory disorders, complement deficiencies, and phenocopies of primary immunodeficiencies. Now, for this particular screencast, we will only be selecting some of the most common examples of primary immunodeficiency disorders. Okay, so let's discuss um, here predominantly antibodies deficiency. Okay, so what do you mean by this particular category? It means that the reason why the person is immunodeficient because he or she lacks immunoglobulins. Let's review what are the importance of immunoglobulins. Immunoglobulins or antibodies are important, particularly if the pathogens are not yet intracellular. Meaning to say, these particular antibodies would have the ability to neutralize harmful effects of pathogens such as viruses, or even in some cases, they can even neutralize toxins. They can bind with bacteria. Okay, so there are several important functions of antibodies. Now, the prefix "a" refers to absence of. Therefore, a gamma globulinemia is the absence of gamma globulin, and gamma globulin is the primary protein component of antibodies. So, what could have caused the antibody deficiencies? Antibody deficiencies are actually caused by genetic defects in B cell maturation or there would be defective interaction between B and T cells. You know why? Because there is a particular component of T cells that would be helpful in the production of antibodies, and that would be your T helper cells. So, again, as a review, there are 5 classes of immunoglobulins. However, when we say predominantly antibody deficiencies, this may involve all immunoglobulin isotypes or may even just include one subclass or even one class only. Okay? So in order to diagnose it, we have to assay the antibodies so that we'll be able to measure its exact amount when compared with the age-matched reference range. Okay, there is an emphasis here with age match. You know why? Because neonate would have a different reference range as compared to adults. So that also with the geriatric. Okay, so our first category here is the Bruton's Agama globulinemia. So it is an X-linked, okay, Bruton's tyrosine kinase. So that's the reason why we call it the BTK deficiencies. So how do we describe it? It is actually due to the presence of the BTK gene, okay, which is actually the loci of this particular gene or the locus of this particular gene is found on the long arm of X chromosomes or particularly the area of the XQ21. Okay, so if a person has this particular BTK gene, okay, so what will happen here, okay, as you can see, the long arm or the Q arm, okay, there would be arrested maturation of the pre-B cell stage, which means that B cell will not normally mature. So, if we're going to look at if we're going to assay or analyze the subset of lymphocytes, you would notice that there would be lack of mature CD19 plus B cells in blood and plasma cells in lymphoid tissue. So, what would happen? The person would be that particular person would lack gamma globulin, so which means that he'll not be able to produce enough antibodies to combat these pathogens. So usually people with Bruton's gamma globulinemia will be treated with gamma globulins in order to augment the lack of this particular protein. I told you a while ago that if it's an X-linked disorder, males would be more predisposed to have it as compared to female. Female would usually be the carrier, but since female would have another X chromosome, so this particular X chromosome could be dominant, and this particular gene may not be expressed phenotypically. Unlike if it's male, male would usually have male has XY chromosome. So there's no other X chromosome in male that would hide it, therefore it will be phenotypically expressed. Hence, females usually serve as a carrier, while male would actually express it phenotypically. However, both sexes could carry it as part of their genotype. Okay. So we also have the so-called common variable immunodeficiency. It is the heterogeneous group of disorders, and this particular common variable deficiency, okay, could either be congenital or acquired, and that makes it different from that of the X-link because X-link is always congenital. So another difference with that of the X-link is that in common variable immunodeficiency, symptoms may begin between 20 to 30 years of age. Unlike in X-link, it is usually manifested right away as soon as you are born. Okay, so in common variable immunodeficiency, um, there is a failure of B cells to mature into plasma cells as a result of B cell or T helper cell defect. So just like your X-linked Bruton's tyrosine kinase or the BTK deficiency, it is also treated with gamma globulins. So moving further, we also have the so-called the predominantly um, antibody deficiencies. So we also have the so-called transient gamma globulinemia. So here, um, that particular in this particular infant has a delayed development of immunoglobulin production, particularly that of the IgG. So, however, it is transient, and when we say transient, transient means uh, it is just temporary. It is not permanent. So, as you can see in the illustration, after 6 months, this infant has actually improved. Okay? So, the skin disorder of this infant, okay, was actually gone. So, perhaps after 6 months, this infant has finally able to produce enough antibodies to combat pathogens. Okay. Now, there are 5 immunoglobulins, but in some cases, there is only one immunoglobulin class that will be affected. And this is actually an example of selective IgA deficiency. In selective IgA deficiency, you'll have low level of IgA. And before we discuss it further, let us review what is the importance of IgA. IgA, particularly that of the secretory IgA, which is a dimer, is important for mucosal immunity. It guards our mucosa. Okay? So, and the reason why out of the 5, only IgA is affected is because of the impaired differentiation to IgA plasma cells. So you have to review again the B cell differentiation. So fortunately, patients may be asymptomatic. That's a good scenario if it's asymptomatic. However, uh, patient would be more susceptible to infection, allergy, and autoimmunity. Okay. So we also have Ig G subclass deficiencies. So again, let's review. There are 4 subclasses of IgG. So it's also possible that you have the 3 subclasses normal and only deficient with 1 subclass. Oh, that's also possible. Okay. We also have the Cd154 deficiency. Okay. So what's the importance of CD154? Okay, so as you can see here in the illustration, CD154 is also known as the CD40 ligand because it binds with um, so this is the receptor site, okay, for CD40, and the one that binds with CD40 is the CD154. So that's the reason why it's also called as CD40 ligand. Okay, so this is the CD40, and then this is the green one here is the CD40 ligand. Okay, the reason why we call it ligand because it binds with CD40. So CD154 is also known as CD40L, wherein L stands for ligand. Okay? So, it is a protein that is primarily expressed on activated T cells, such as the T helper cells here, and it is a member of the TNF or the tumor necrosis superfamily of molecules. So, what's primarily the function of the CD154? Okay, it binds to CD40 on antigen presenting cell. So in this case, in this illustration, the antigen presenting cell is the B cell. Okay, so it binds on the CD40 on antigen presenting cells, which leads to many effects depending on the types of the target cell types. So what will happen if the patient lacks CD154 or the CD40L? So if the patient lacks CD154, it will result to a defect in this gene will result in ability to undergo immunoglobulin class switching. Okay, so there would be what associated hyper Igm syndrome. So there would, as you can see here in the description, there would be decreased level of IgG, IgA, and IgE. Okay, because of the defect in B cell switching. So there would be hyper IgM. So you have many IgM, but you will lack IgG, IgA, and IgE. So absence of CD154 or the CD40L stops the formation of the germinal center. Therefore, it will prohibit antibody affinity maturation. And without that, uh, adaptive immunity, particularly that of the humoral immunity, will be greatly affected. Okay, so that's CD154 for you guys. Okay, so at this point, let's talk about the combined immunodeficiency. Okay, so the illustration here is actually an example of procedure of the bone marrow aspirate. Okay, and combined immunodeficiencies involve a T cell deficiency. Okay, it affects complex uh, cell mediate. Although it involves T cell deficiency, it may actually affect both cell mediated and humoral immunity as well. Why? Because one component of the T cell, which is the T helper cell, is also necessary for the production of for the activation of B cells, and B cells are important for production of antibodies, and antibody production is an example of humoral immunity. So therefore, even if there's a T cell deficiency, it will affect both cell-mediated and humoral immunity as well. So therefore, the possible treatment would be bone marrow transplant, as you can see here, to reconstitute. So we have here severe combined immunodeficiency. Okay, so it is a group of a very serious PIDs, and it all involve a defect of normal T cell development. It may affect B cell and natural killer cell development depending on the type that you have. Okay, so again, it could be X-linked recessive. So if it's X-linked, as what I've explained to you, in X-linked, the one that is most commonly affected would be male. Okay, if it's X-linked, the reason why it is X-linked is because of the IL2RG gene mutation. Okay, so if it's X-linked, you would expect the phenotype to be um, T negative, B positive, NK positive / negative phenotype, which is actually the same phenotype even if it's autosomal recessive form. So the only difference that in X-linked, there is a particular gene mutation that actually that have actually caused it. Okay, so an illustration here as an example of an autosomal recessive form of the SCID. So in this particular example, both parents are carriers. So if both parents are carrier, 25% chance, okay, 25% or 1 out of 4 or 25% of the children will be affected. Half of the children would be carrier, and again, another 1/4 would be unaffected child. So if both parents are carrier. So that's the reason why it is an example of autosomal recessive disorder. So as you can see here, here's a bubble boy. So this boy has SCID. Let me go back. So this boy has SCID. So he has been living inside the bubble all throughout his life because you have to keep the environment sterile. So why? Because he doesn't have any defense to protect himself against pathogens. So he has to stay inside the bubble. So syempre, you have to adjust the size of the bubble as this boy grows up. Okay, so again, in SCID, you have a very low amount of T cells, which affects both the cell-mediated and humoral immunity. Another example here is the Wiskott-Aldrich syndrome. So here, it is another example of rare X-linked recessive primary immunodeficiency disorder, and it is characterized by number 1, immunodeficiency, and then an allergic reaction, eczema, and thrombocytopenia. Thrombocytopenia is the condition wherein you lack platelets, okay, and that is the reason why you see petechiae all over the skin. So it is a defective T cell function, and there is a decrease in IgM, normal IgA, and IgG, but increase in IgE. So an increase in IgE perhaps explains why there is an eczema or a form of hypersensitivity reaction. So the primary culprit is a defect in CD43, It is an integral membrane protein needed for the signal transduction in lymphocytes. So the gene that is associated with it is so easy to remember. We call it as the WAS gene, or the Wiskott-Aldrich syndrome gene. So the George anomaly. So the George anomaly is another example of developmental abnormality in third and fourth pharyngeal pouches in embryo. So this is where the thymus, okay, so this is where that particular place, the third and fourth pharyngeal pouches in embryo, would be important for the development of thymus. Okay, so most patients have deletions in chromosomes number 22. So because of the abnormality in the third and fourth pharyngeal pouches, you'd expect that person to have an underdeveloped thymus. And thymus is where T cells are being educated. So there would be decreased number of functional T cells. Incidentally, people with the George anomaly would also suffer from hypoparathyroidism and hypocalcemia. So again, bone development is affected. Hence, as you can see, there's an obvious disfigured development of bone structure. So the face appears not normal. Okay, so people with the George anomaly may suffer from cardiac abnormalities, mental retardation, and abnormal facial features. So if we're going to do the karyotype or karyogram, if we're going to examine the karyogram, you would notice that majority of patients with the George anomaly would have deletions in chromosomes number 22. Okay, so another example of immunodeficiency disorder here is called ataxia telangiectasia. So again, it is a rare autosomal recessive syndrome. So what does it mean, ataxia telangiectasia? So ataxia is an involuntary muscle movements, while telangiectasia actually refers to capillary swelling and red blotches on skin. So the reason why this occurs is there because of the low number of T cells and defective antibody response. So again, the gene is called AT gene. So AT gene is supposed to be encoded in chromosomes number 11. So if there is a mutation of AT gene on chromosomes number 11, this will result to defective DNA repair and gene rearrangement in T and B cells. Hence, there would be what? Involuntary swelling, and again, capillary swelling. Okay, so as you can see, these are examples of patients with AT. Okay, so we also have defects in phagocytic cell function. So here, CGD, or the chronic granulomatous disease. It is a group of disorders inherited as X-linked recessive or autosomal recessive. So neutrophils would be unable to generate oxidative burst, and oxidative burst is important so that that particular neutrophil will be able to completely perform the supposed outcome of phagocytosis, which is digestion of the ingested pathogens. So without the oxidative burst, that will not be possible. Hence, there would be decreased killing of catalase-positive organisms. So in order to test it, in the laboratory, we can possibly perform the NDT, or the nitro blue tetrazolium test, and the dihydrorhodamine assay, or the DHR assay. So nitro blue tetrazolium test, or the NDT test, is a semi-quantitative assay, and the main objective of the test is to evaluate the phagocytic function of the PMNLs, or the neutrophils. So cells that has enough granules, okay, enough myeloperoxidase enzyme, can reduce a colorless NBT into a blue-black deposit within the cell. Okay? However, this is not possible for patients with CGD. In patients with CGD, the PMLs or the neutrophils will not turn blue. Hence, this particular cells here is an example of neutrophils coming from patient with chronic granulomatous disease. So, chronic granulomatous disease, I could say, is an example of phagocytic defect disorder. Again, another category would be complement deficiencies. Complement, okay, let's review what complements are. Complements are serum proteins, and complements are part of our natural immunity, and complement can actually destroy or can cause cytolysis of bacteria. And the most abundant component of complement is C3. Okay? So, deficiencies in complement components could be associated with lupus-like syndrome. Okay? C2 deficiency is the most common. C3 deficiency is associated with recurrent infection with encapsulated bacteria. Why? Again, complement would have the ability to cause their cytolysis. So without enough C3, you'll not have enough gun of natural immunity to fight off pathogens. Okay? Such as, for example, Neisseria meningitidis. So deficiency in C1 esterase inhibitor may also cause hereditary neuroangioedema. Okay, so how do we screen for suspected immunodeficiency? First, we can look into the patient history, and we do the routine tests such as CBC, and then doctors would now start to request immunoglobulin levels. So although this is quite expensive, because most of the time it will require you to have the immunofixation electrophoresis. And then isohemagglutination to determine or to screen for the natural ABO antibodies. And then antibody response after vaccination will also be possible. Delayed hypersensitivity skin reaction for cell-mediated immunity would also be determined. Okay, so that you'll be able to determine if a person's T cell are still functional, if they can still cause erythema, okay, in skin type and in hypersensitivity type skin reactions. Okay, CH50 assay for complement function and DHR assay for neutrophil function, the one that I have discussed a while ago. Okay, so do you know that if you are immunodeficient, you'll not be able to give positive reaction in skin testing, such as in tuberculin testing or in lepromine testing, okay, because of the deficiency in T cell functions. Okay, to confirm, we'll be using more sophisticated assay such as the immunophenotyping and flow cytometry to determine the number of B cells, helper T cells, cytotoxic T cells, natural killer cells. So we can do the flow cytometry, for example, which will do the particular immunophenotyping, wherein we will gate the cell of interest and then let the machine analyze it. And another example of confirmatory testing would include genetic testing, like for example karyogram, mitogen assay for T cell and B cell, okay, and then other assay for T cell activation. So there are commercially available kits such as the quantiferon TB and T-spot, okay, and another one is the Cyclex immunoassay. Okay, so these are examples of confirmatory testing for immunodeficiency. And then, of course, as what I've mentioned, you may want to assay, or doctors may want to know the level of immunoglobulins, and it is quite expensive because it is not being done routinely. So it can be measured quantitatively by using the nephelometry principle. Remember the nephelometry, the amount of you measure the amount of light that is blocked, or RID, radial immunodiffusion. So remember the Fahey and the Mancini method. So that's part of the RID. But serum protein electrophoresis, but a more specific way of doing it would be, or a more sensitive way of measuring it would also include the immunofixation electrophoresis, wherein you'll be comparing the bands from that of the standard to determine whether you lack a particular type of immunoglobulin or not. So in this case, for example, a patient doesn't have IgM. So kappa and lambda, this refers to the light chains of immunoglobulins. Okay, so there are several commercially available kit for immunofixation electrophoresis, and Beckman Paragon IFE gel is an example of such. So newborn screening is very important. Okay, why? Because you want to determine whether the child has has this particular type of immunodeficiency as early as possible, so that you'll be able to mitigate its presence if in case the child has immunodeficiency disorders. So usually, in newborn screening, we are screening for the Tregs, or the T cell receptor excision circles. So these Tregs are produced as a byproduct of the TCR gene. So we usually quantitate Tregs by means of molecular diagnostics such as PCR, so that we'll be able to evaluate the number of T cells that are present. So in the United States, it is being mandated to screen for T cell deficiencies. So fortunately, in the Philippines, we also have, this is also mandated by our law, um, um, particularly if your child is born in the hospital. So you'll be asked to send samples to UPNIH for the screening of immunodeficiency, not just immunodeficiency but other genetic disorders. Okay, so that's why newborn screening, or NBS, is very important. So that would be all. I hope you learned something today. So see you again next time in our succeeding screencast. So again, I'm Dr. Spache Basit saying God bless and stay safe, everyone.